Welcome to this deep dive. If you're listening to this right now, you are a plastic surgery resident and you are staring down the barrel of your board exams, like the FRCS.
And you're in the room with two plastic surgeons. Our mission today is simple: high-yield question and explanation.
Exactly. We are taking the massive, frankly overwhelming topic of sternal wound management and chest wall reconstruction, and we are going to extract the exact insights, the testable nuances, and the clinical algorithms you need to pass.
We're keeping it focused, but we are going to make sure you actually understand the why behind the facts so they stick.
So let's get straight into it. When we talk about sternal wounds, the very first conceptual hurdle is differentiating between superficial and deep sternal infections. It sounds basic, but the clinical implications are massive.
It really is the foundation of everything else we're going to discuss today. I mean, a superficial infection is essentially contained. It involves the skin, the subcutaneous tissue, and it might go down to the pectoralis fascia, but that is where it stops. Because it's localized, it's generally manageable, usually eradicated with a solid course of systemic antibiotics. But the moment that infection breaches the fascia, you are dealing with a deep infection, which is mediastinitis.
And that is a completely different beast.
Completely.
It's a beast that affects anywhere from 1% to 5% of all median sternotomies. It is highly life-threatening and demands aggressive surgical debridement followed by flap coverage. But for the boards, you can't just know how to treat it. You have to know how to predict it. So if you're evaluating a patient preoperatively, what are the classic risk factors that should immediately set off alarm bells?
Well, patient factors are huge here. You were looking at diabetes, obesity, chronic obstructive pulmonary disease, osteoporosis, and a history of smoking.
Spot on. And beyond the patient's inherent physiology, there are critical surgical and systemic factors.
Right.
If the cardiothoracic surgeons utilize bilateral internal mammary arteries, the IMAs, that significantly devascularizes the sternum. Plus, any revision operations or a prolonged stay in the ICU also exponentially increase the risk.
Which brings us to a fantastic clinical pearl that connects directly to those risk factors.
Let's hear it.
Because we know this specific subset of patients is at a much higher risk of developing a sternal complication, it has fundamentally changed the initial surgical approach to how the chest is closed. It really shifted the entire fixation strategy.
Right, because traditionally cardiothoracic surgeons would close the sternum using circlage wire.
Exactly. But for these high-risk patients, like the diabetic obese smoker, for example, we're increasingly seeing a shift toward rigid fixation right from the start. Using plates and screws provides absolute stability.
Which is crucial because sternal instability is a massive catalyst for deep infections. All right, so let's say the preventative measures fail, and a patient develops an infected median sternotomy wound. On the exam, you are guaranteed to be asked to classify this. And that means knowing the Paralero classification inside and out.
But Paralero isn't just a list to memorize. It is essentially a map of the infection's depth and timeline.
Let's break down the three types. I'll take type I. This occurs within the very first week post-sternotomy. Clinically, you're going to see a serous sanguineous discharge.
But the crucial negative findings here are that there is absolutely no evidence of cellulitis, no costochondritis, and no osteomyelitis.
Exactly. And because it's caught so early, you primarily treat type I with systemic antibiotics, though occasionally you might need a single-stage operation to wash it out.
But if that timeline pushes to between 2 and 4 weeks post-op, the entire clinical picture shifts dramatically. This is Paralero type 2. At this stage, you're no longer dealing with a simple discharge.
You are looking at frank, purulent mediastinitis.
Yes, accompanied by established osteomyelitis. And you may or may not see costochondritis. Systemic antibiotics alone are not going to save this patient. This requires immediate, aggressive intervention. You have to take them to the operating room, debride the necrotic tissue, remove all foreign material like the sternal wires.
And then you are left with a significant dead space that must be managed with a well-vascularized soft tissue flap.
Exactly.
And then we have Paralero type 3, which is the chronic presentation. We're talking months or even years after the initial surgery. The hallmarks here: chronic draining sinus tracts, deeply established costochondritis, osteomyelitis, and very often retained foreign bodies from that initial operation serving as a nidus for the infection.
And the management here is absolutely grueling. You can't just fix it in one go. It requires repeated, staged debridements to finally clear the infection, eventually followed by flap obliteration to fill that resulting dead space.
So we've established that types 2 and 3 leave us with a massive void in the chest that needs addressing. But before we mobilize flaps, we have to talk about how we prepare that wound bed, which brings us to negative pressure wound therapy, NPWT.
This technology has truly revolutionized sternal wound management. Its widespread use has actively reduced the need for immediate, radical surgical intervention. It's lowered the reoperation rates for persistent infections and significantly curtailed hospital stays.
But on the exam, they won't just ask what NPWT is. They'll ask you for the precise physiological mechanisms. Why does it work so well on a sternal wound? There are 4 key physiological effects you need to lock in.
Let's run through them. First, the macrostrain and microstrain increase local blood flow to the wound edges. Second, the sealed system actively decreases the local bacterial count.
Third, it rapidly enhances the formation of granulation tissue. And fourth, and this is somewhat unique to the chest wall, the negative pressure actually provides splinting and chest stabilization, which inherently improves the patient's respiratory function.
Because of those incredible physiological benefits, NPWT can actually be a definitive treatment for a very specific subset of patients. If you have a highly debilitated patient who simply cannot withstand the physiological insult of a major flap reconstruction.
Applying NPWT and letting the wound heal by secondary intention might be your only and, frankly, best option.
But, and this is a massive but for your clinical practice and your exams, there are strict red flags where NPWT is absolutely contraindicated as a definitive treatment. It can only be used as a temporary bridge to the operating room.
Let's list those red flags. If your patient has bacteremia, they need surgery. If the wound depth is greater than 4 centimeters, if there is visible exposed bone, or if you have gross sternal instability, surgery is completely mandatory. You are just using the vacuum dressing to temporize the wound while you prep them for theater.
Exactly. And once you get them to theater, you perform your debridement, remove the necrotic bone, send tissue off for microbiology, and you are left staring at a massive dead space right over the heart. You need well-vascularized tissue to fill it.
So let's walk through the workhorse flap options for these Paralero type 2 and 3 defects, because the anatomical nuances here are highly testable. Let's start with the classic, the pectoralis major flap.
It's your primary workhorse. And it is incredibly versatile because you could utilize it in 2 main ways. The first is as a turnover flap. If you design it this way, you are basing the blood supply on the medial perforators coming directly off the internal mammary artery. Obviously, this requires the IMA to be completely intact.
Which isn't always a given.
Right. So the second option is designing it as a rotation advancement flap. This variation is based on the pectoral branches of the thoracoacromial axis.
And the nice bonus with the rotation advancement technique is that you can actually harvest part of the anterior rectus sheath right along with it to help cover the very inferior portion of the sternum.
Which is a perfect segue to the rectus abdominis flap itself.
Right.
This is guaranteed to be an exam topic because the vascular supply involves a classic anatomical trick question. You can use the rectus as a muscle-only flap or as a myocutaneous flap with a vertically oriented skin paddle, the VRAM.
The crucial high-yield concept here is its dominant blood supply from above, the superior epigastric artery. Why is that specific vessel so important in sternal reconstruction?
Because the superior epigastric artery is the direct anatomical continuation of the internal mammary artery.
Exactly. And put yourself in the shoes of the cardiothoracic surgeon who just did a CABG before this wound broke down. What vessel did they love to use for their bypass grafts?
The internal mammary artery.
Right. If the IMA was harvested for that CABG, the primary blood flow to your superior epigastric artery is completely gone. In that exact, very common scenario, the flap's perfusion is severely compromised.
So to safely use the rectus flap then, you must ensure that muscle perfusion is maintained via the 8th intercostal artery. That is the detail examiners want to hear.
Also, purely from a donor site perspective, when you harvest the rectus muscle, you must prevent abdominal hernias by transposing the muscle while rigorously leaving the anterior rectus sheath in situ on the abdominal wall.
Absolutely.
Yeah.
Another fascinating option for these deep, irregular sternal wounds is the omental flap. The omentum is incredibly pliable. It is based on either the right or the left gastroepiploic pedicles.
Because it's just fatty tissue and vessels, once you transpose it up into the chest defect, it obviously requires a split-thickness skin graft over the top.
But it is brilliant for this application because it contours perfectly into deep, irregular mediastinal recesses. Even better, it brings its own intrinsic, highly active immunological function directly to the site of the infection.
But there is a massive catch. To get the omentum, you have to open the pristine abdominal cavity. So you are taking a patient with a raging, purulent mediastinitis, and you are opening a communication pathway directly into their abdomen.
There's an inherent serious risk of spreading that infection downward.
Right. So to mitigate that risk and to minimize the general complications associated with a major laparotomy, the standard of care is increasingly to opt for a laparoscopic harvest of the omentum whenever possible.
So we've covered the soft tissue management of sternal infections. Let's broaden our scope and transition to massive chest wall reconstruction, specifically the kind of defects you see following radical tumor ablation or severe trauma.
In these scenarios, the structural integrity of the chest itself is gone. We need to know exactly when skeletal support is mandated and how the patient's physiology tolerates different anatomical defects.
The universally accepted clinical consensus is that skeletal reconstruction is absolutely indicated for any chest wall defect that is larger than 5 centimeters in diameter, or any defect that involves the segmental loss of 4 contiguous ribs.
If you don't reconstruct that, the patient will suffer from severe paradoxical chest wall motion leading to respiratory failure. But how well a patient tolerates a defect before reconstruction heavily depends on where it is. Mechanically speaking, anterior and posterior defects are generally much better tolerated by the patient than lateral defects.
And here is a phenomenal paradox that examiners love to test. You might assume that a patient who has undergone extensive radiotherapy would be much harder to manage because their tissues are so compromised. But structurally, radiotherapy defects may actually be better tolerated than fresh traumatic defects.
Right, because of the stabilizing properties of the dense fibrosis that forms post-radiation. That heavy scarring makes the surrounding chest wall remarkably stiff, which physically prevents paradoxical movement, even if the local tissue quality is absolutely terrible.
Let's look at the actual materials we use when we do need to reconstruct the skeleton. You essentially have 3 categories: autologous, alloplastic, and biological.
Starting with autologous tissue, your primary options are split rib grafts, harvesting the iliac crest, or taking the fibula. The exam pearl you must drop here is that while non-vascularized bone grafts can be used, vascularized bone is always preferred.
Because a vascularized graft results in significantly less bony resorption and yields much greater rates of actual bone union.
Exactly. When we look at alloplastic or synthetic materials, the list of meshes is extensive, and you need to group them logically in your mind.
Let's start with polypropylene knitted mesh. This is a permanent material, and its key feature is that it induces fibrovascular infiltration, allowing the patient's tissue to actually grow into and incorporate the mesh. You need to know 2 specific types: single knit fabrics, like Marlex, which are expandable in one direction but remain rigid in the other, and double knit fabrics, like Proline, which are highly flexible and expand in both directions.
And then you have your other synthetic polymers to recognize for multiple choice questions. You have polyester, which you'll see as Merceline or Dacron. There's polyglycolic acid, which is Dexin. You have expanded polytetrafluoroethylene, known as Gore-Tex, polydioxanone, which is PDS, and polygalactin, which is Vicryl.
But when we are dealing with massive structural deficits that require rigid, unyielding support, a simple mesh won't cut it. That is where we use a composite technique, specifically the PMMA sandwich.
The PMMA sandwich is brilliant because it allows you to custom contour the material perfectly to the defect while curing into absolute rigidity. The construct utilizes 2 layers of polypropylene mesh and a core of polymethylmethacrylate, or PMMA bone cement.
The technique is specific. You cut the first layer of mesh generously, leaving plenty of excess material on the borders so you can securely suture it to the native ribs or sternal edges. You place that mesh down, then you mix the PMA and apply it directly over the defect area to fill the void.
Finally, while it's still malleable, you place a second layer of mesh right on top of the PMMA, effectively sandwiching the cement between the 2 layers of mesh.
But there is a massive, highly testable warning associated with this technique. As the PMMA cures, it undergoes a vigorous exothermic reaction. It produces a tremendous amount of heat. You must rigorously protect the underlying vital structures like the heart and lungs from thermal injury by irrigating with cold saline during this phase.
And there is a second absolute contraindication here. You must never, ever use a synthetic mesh repair or a PMMA sandwich in a previously irradiated or heavily contaminated field. Doing so dramatically increases the risk of catastrophic infection, sinus tract formation, and inevitable implant exposure.
Which is exactly the clinical scenario where biological materials become the absolute gold standard. Acellular dermal matrices, or ADMs, they are derived from either human or animal sources.
Unlike synthetics, which remain foreign bodies forever, ADMs are gradually revascularized and entirely remodeled into the patient's own autologous tissue, all while maintaining their initial structural integrity. Because they become living tissue, they are far more resistant to infection, and they incorporate beautifully into irradiated, hostile wound beds.
You need to be able to classify these ADMs by their source. Let's start with human allografts. The primary one to know is alloderm. It is a cadaveric dermal allograft. The manufacturing process chemically and physically removes all the cellular components to prevent rejection. But crucially, it preserves the extracellular matrix and the vital basement membrane, which acts as the scaffold for the patient's own cells.
Now, a specific note for those of you taking the FRCS in the UK. While alloderm is standard practice in the United States, it is not currently available in the United Kingdom for this specific reconstructive purpose.
Moving on to the xenografts, you group these into porcine and bovine sources. For porcine, derived from pigs, you have permacol, which is a cross-linked ADM, meaning it takes longer to degrade. You have stratus, which is a non-cross-linked ADM. And you have surgisis, which is unique because it's derived specifically from small bowel submucosa.
For bovine options, derived from cows, you have Tutopatch and Veritas, both of which are remarkably strong because they are made of pericardium. You also have Surgimend, which is another excellent non-cross-linked ADM option.
Okay, we have stabilized the skeletal vault. Now we need to cover it. Let's move to our final section, soft tissue cover for the chest and posterior trunk. If the skeletal defect is small enough that it doesn't require rigid stabilization, you can reconstruct the defect with soft tissue alone.
Let's run through the pedicled muscle flaps and their specific regional indications. The pectoralis major is your go-to for central, supraclavicular, lateral, and axillary defects. It can also be aggressively transposed internally to obliterate deep intrathoracic dead space.
The latissimus dorsi, or LD flap, provides a massive surface area and is fantastic for large anterior anterolateral, posterior midline, and paramedian defects.
The rectus abdominis is your primary choice for anterior defects, particularly those located inferior to the xiphisternum. And its overlying skin paddle is incredibly versatile. You can orient it either transversely or vertically depending on the defect's geometry.
Now, here is a flap that you will rarely see used in modern clinical practice, but examiners absolutely love to test it because of its specific anatomy. The external oblique flap. This is useful for reconstructing the anterolateral chest wall. What you need to know is its vascular anatomy.
Right. It has a type V blood supply. Its dominant vessel is the deep circumflex iliac artery, while its secondary segmental supply comes from the 5th through 12th posterior intercostal arteries.
When you design the overlying skin paddle, you plan it as a laterally based hatchet flap. When you elevate this correctly, its arc of rotation is remarkable. It can reach all the way up to the second intercostal space and can even extend 5 centimeters beyond the midline.
And of course, you can always mobilize local tissues using fasciocutaneous or perforator flaps if the defect allows. And, as we mentioned earlier, the omentum can always be tunneled up subcutaneously to provide broad, soft tissue cover, assuming you are willing to graft over it.
But what if you were dealing with a defect where a pedicled flap simply isn't an option? You need to know the strict indications for free tissue transfer in chest wall reconstruction.
Free flaps are indicated for salvage operations after a primary pedicled flap has failed. They are essential for massive defects that are simply unreconstructable with local tissue, which is incredibly common post-radiotherapy.
You use them for defects that are physically inaccessible to the arc of rotation of any pedicled flap, and for obliterating massive intrathoracic dead spaces where local muscles just don't have the bulk.
When you decide a free flap is necessary, your primary options are highly specific to the defect's needs. The tensor fasciae latae, or TFL flap, is exceptional because it provides excellent soft tissue cover while bringing along incredibly thick, strong fascia that can actually substitute for skeletal support.
The latissimus dorsi can be harvested as a free flap, And the beautiful anatomical trick here is that if you include the serratus anterior muscle on that exact same subscapular pedicle, you achieve massive chimeric coverage.
The TRAM, VRAM, or DEP flaps are often selected because transferring them freely gives you infinitely more versatility for complex three-dimensional insetting than you would get by leaving them pedicled to the superior epigastric.
The anterolateral thigh flap, or ALT, is a modern workhorse. It's incredibly pliable, but you can also include the fascia lata for structural support or incorporate the vastus lateralis muscle if you need to fill a deep dead space.
Finally, the scapular and periscapular flaps. These are supplied by the circumflex scapular artery, which is a branch of the subscapular artery. It gives off a transverse cutaneous scapular branch and a vertical periscapular branch, offering fantastic design flexibility for complex skin defects.
Let's bring it all home with the final anatomical region, posterior trunk reconstruction. These defects usually stem from congenital issues like spina bifida or acquired causes like massive trauma, deep pressure ulcers, iatrogenic injury following complex spinal instrumentation, or aggressive tumor resections.
In this region, flaps are strictly required. You cannot rely on healing by secondary intention, and simple skin grafts are completely inadequate. They simply are not durable enough to withstand the shear forces of the back. If you have exposed spinal bone or orthopedic hardware, you strictly require thick, vascularized flap coverage.
Let's break this down by region. I will name the area, and we will outline the specific flap options and the testable anatomical notes. First, the cervical region.
For defects over the cervical spine, the trapezius flap is your absolute best option. It can be raised as a pure muscle or a myocutaneous flap. It is based on the superficial branch of the transverse cervical artery, which originates from the thyrocervical trunk.
The critical exam pearl you cannot miss here. You must leave the superior fibers of the trapezius muscle completely intact and innervated.
If you detach them during your harvest, the patient will suffer from a debilitating, permanent drop shoulder.
Excellent. Moving down to the upper thoracic region.
Here, the latissimus dorsi is your primary, most robust choice. You can also utilize the trapezius flap, but this time raised inferiorly on the posterior intercostal perforators, though frankly that is rarely required if the LD is healthy and available. The scapular or periscapular flaps are also excellent, reliable options for this zone.
Continuing down to the lower thoracic region.
The LD flap is still very useful here, but because of the lower anatomical location, its primary pedicle might not reach, so it is usually raised in reverse based on its secondary segmental supply from the posterior intercostal arteries.
If the defect is shallow and you don't need muscle bulk to obliterate dead space, you can elevate local intercostal artery perforator flaps. The omentum can be brought out here, but it is strictly considered a last resort.
Finally, the lumbar region.
The modern workhorse for the lumbar spine is the lumbar artery perforator flap. This has largely superseded the older, traditional transverse lumbosacral flap. The reason is simple vascular anatomy. The transverse lumbosacral is a random pattern flap relying on the subdermal plexus, making it prone to distal necrosis.
Basing your flap on a clearly identified, anatomically mapped lumbar perforator makes the survival vastly more reliable. Other options include the superior gluteal artery perforator, or SGAP flap, transposed superiorly. You can attempt an LD flap based on its segmental supply, but be warned, it frequently cannot reach inferior lumbar defects without tension, and again, the omentum remains your absolute last resort option.
Before we wrap up this session, I want to leave you with a thought that extends beyond the immediate revision text we've just covered. We spent a lot of time today memorizing the intricate details of the PMMA sandwich and the pedicled muscle arcs of rotation. But consider how the future of chest wall reconstruction is rapidly evolving. We might soon shift completely away from implanting rigid foreign plastics and sacrificing highly functional core muscles. The field is moving entirely toward 3D printed bioabsorbable scaffolds that are custom designed for the defect and seeded directly with patients' own stem cells. That technology could radically change the algorithms you just memorized today, effectively regenerating a living, breathing chest wall rather than just patching it.
It is a compelling look at exactly where this specialty is heading, and something to keep in mind as you transition from the exam hall to the operating theater. All right, listen closely. Press follow on the show right now so you do not miss any of our future rapid-fire revision deep dives. Rate the show if this session successfully cemented your knowledge and clarified those complex algorithms. Leave a comment below with the specific clinical topics or exam sections you want us to cover in upcoming sessions. And most importantly, get a premium subscription right now. That is the only way to unlock exclusive access to our specialized journal club and our clinical cases deep dives, which are absolutely essential to guarantee you are fully prepared to pass the FRCS. Efficient studying is everything. Get back to the books.